How many of you here are GPs? Raise your hands. A number, about half. Okay. So I've got to be careful that half of you are not GPs, so that's fine. Well, this is about generalism in medicine, not necessarily about general practice as such. And the title is, Has It a Future? And as Chris has said, there's been this inquiry recently, a commission of inquiry, and does medical generalism have a future? And the reason for that is a sort of feeling, I think, coming partly from the College of GPs, which obviously has a strong vested interest in generalism, and also from the Health Foundation, which has a broader remit, but whose chief executive is in fact Martin Marshall, himself a former GP. And they're thinking that the situation today is that generalism is no longer obviously the good thing that we thought it was, or some it was, to be reviewed. And the three sort of pressures that the Commission thought were really making this timely were the increasing complexity of medical care, the fact of easy IT access for so many people, meaning perhaps that, you know, they really can choose their own specialist, don't need a generalist as a guide, gatekeeper. And also the feeling that general practice, anyway, is possibly being squeezed by specialists from one side outraging into the community, and by maybe nurse practitioners from the other side saying, well, we can do it just as well as you. So I'll deal with some of these points. But I would say, first, that as far as complexity is concerned, medicine's always becoming more complex, and certainly when I was first in practice in the early 70s, we were very influenced by a report in the 1960s saying that medicine was far too difficult for general practitioners and we had to split it down into specialties, and that proved to be wrong. So, you know, we've been here before in a way. So, has it a future? Well, this is the outline of my talk. Really, 8 slides, in fact 9, because 2 is divided, but basically that's what I'm going to cover. So first a little bit of history, then more about what we mean by a generalist. Third, something about the parts of generalism that are not in primary care. Then a specific word about gatekeeping, the evidence for medical generalism, and it's largely from the late Barbara Starfield and her team. Then some more general political considerations about generalism in the marketplace. Specific brief look at non-medical generalists. And finally, I'll just take a selection from some of the recommendations for the future that the Generalism Commission has just made. Its report just came out on the web in the last week. I was lucky to get a hard copy because I'm very old and I find it easier to read a hard copy. So, let's go on to history. Well, really, it's more a history of specialism. I would say that the archetypal original medicine man was a generalist, inasmuch as he or she, probably he, would take on any kind of problem. But specialism does go back a long way, and it's mentioned at least as far back as the 5th century before the Christian era by Herodotus, the famous Greek historian. And that was about organ specialties, like somebody who was very expert in the eye. And specialism really then took off, though, more recently in the time of the Enlightenment, the intellectual Enlightenment in Europe, starting with pediatrics in France in the mid-18th century. And almost the same time, actually, in London, there was a dispensary for children opened in the mid-18th century. And now specialists form the majority of doctors in nearly all developed medical economies. Less of a majority in the UK than most others, but still specialism growing in the last decade far more than generalists. with this rise in specialism, generalists have struggled for parity. Parity of esteem, parity of money, prestige. And this goes back at least 100 years, more. 100 years ago, the general practitioners in the BMA were saying, oh, we're just as good as specialists, and they don't know about the whole patient, and they shouldn't be allowed to see patients without us seeing them first. So there's a long sort of story of the generalists becoming sort of underdog. So why is that? And really, the question is, what do we mean by generalist? Do we mean an expert with an overview, or do we mean the lowest common denominator with that following phrase, the jack of all trades and master of none? Well, think about generalism outside medicine. Generalism is actually widely distributed. Think of generals. A general in the army is very important, right at the top, and has an overview. A general manager in a private company is a very important person. And these people are senior, they're wise, they're experienced. And indeed, the transition to become a general manager can be quite a difficult thing for somebody who's risen through various specialties in a company. But as I say, in medicine, the status has been rather low. I mean, I was at St. Thomas's in the 1960s, and I well remember a specialist telling me and a colleague we were the only two people on his ward round. Something had gone wrong. He didn't show up very often. So he took us into his office and said, among other things, he said, of course, you won't be considering general practice. Only fools go into general practice. And that's how it was. And really, it was rather surprising that I myself got into general practice. It was, as I've told some of you before, it was on the advice of a very wise and broad and generalist, if you like, neurosurgeon. So there you go. A super specialist recommends me, points me towards being a generalist. And really, the thing was, for me, I'd never done it before. I had no idea. It was great. So that's that. Low status in recent past. The status has got better, I think, since I was a student. But it still ain't perfect. And those of you teaching students now will hear, I'm sure, even last week, how some of your specialist colleagues in this great London complex of teaching hospitals will have been some way talking general practice down a little. Maybe. Maybe. Public perceptions vary a lot. But I was just going to read to you an American view on generalism from the point of view of somebody wanting an opinion about something. The expert generalist concept is supported from the world of American management by Nichols. His summary reads, when considering the use of a consultant, it's important to know if you require the services of a generalist or a specialist. You might require both. Generalists are usually better at helping you define the problem. Specialists tend to frame the problem to fit their solutions. Either can be of help once the problem has been defined. Neither will be of much help if their need for control is at odds with yours. Choose your consultant with care and give thought to the difference between a generalist and a specialist. And this point nicely describes the contrasting relationships that specialists and primary care generalists have with their patients. Thus, the concept of expert generalism is recognized in society outside of medicine. So what are the special attributes of an expert generalist? Well, I've mentioned the willingness to take on all types of problem, a broad diagnostic framework. And this goes beyond biomedicine. In diagnosis, a generalist should take into account subjective, social and psychological and biographical characteristics. This is therefore, these values are called patient-centered. Now, of course, I've spelled it wrong. Patient-centered, it should be. I think everybody in medicine claims to be patient-centered these days, but really what we're meaning is this broad approach and interest in the individual more than the disease. Then we're talking about practicing in the context of where our patients are, in the community, with its particular epidemiology and its particular social characteristics. And the output, at the end of the day, the sort of health gain or the benefit or whatever, is technical, but it's also emotional and subjective. And these are all things which the generalist will be interested in. This obviously is not specific to general practice. It sometimes is easy when talking about generalism to seem to be denigrating the abilities and scope and skills of specialist colleagues. I don't mean to do that at all. All I'm saying is that these characteristics, these attributes, are best or most expressed in general practice, as a rule. But, of course, it's not confined to primary care. Think of A&E. Yes. Think of care of the elderly. Think of acute medical intake. Really, it's very interesting. On the commission, the Journalism Commission, we were addressed by a very prominent A&E specialist who was very impressive, I may say. And he made it quite clear to us that generalist diagnostic expertise was at a premium in this very first stage of seeing a patient with a completely undiagnosed, undifferentiated condition. And that as far as the trust was concerned from a financial point of view, that saved money because it stopped waste. It made care more appropriate. When we come to the care of elderly, we're talking about the huge impact of multimorbidity. It was recognized years ago. In fact, the basis for the specialty of geriatrics, as it was then called, was the realization that most older people had more than one condition. And so a specialist looking after them had to be expert in more than one condition. Acute medical intake is a bit like the A&E, although not all the patients have been through A&E. But it allows sorting. And again, it's become more difficult from the hospital point of view to staff acute medical intake as the specialists become more and more specialized. And we heard about this on the commission from a number of hospital doctors. Finally, medical managers. We heard from trust managers and trust experts that they really wanted medical managers who were generalists and who were able to act as such, with a broad overview, to be senior and wise, just like the sort of people we were hearing about as officers, chief executives in companies. So this is all very important, but in the big picture of how many generalists are there in the UK or most other Western countries, most of them are actually general practitioners in primary care. There is this tendency to note that in this secondary care category of generalists that I've mentioned, they tend to put the generalist at the front end. They really want the generalist to do high-level sorting diagnostic work. Contrast if the situation in primary care where there's been a move to use nurses for initial triage in the last decade or two. And you know what general practice is like. There's always a tendency and a temptation to say, oh, there are all these rather unimportant patients with minor conditions coming in. They can easily be sorted by somebody with less medical training. I'll come back to the question of nurse practitioners later on. But it is interesting that some trusts and some nascent GP commissioning bodies are very interested in this question of whether the nurse triage is really cost-effective for them. Another big element of the function of the generalist primary care doctor is gatekeeping. This term is sometimes misunderstood, but it's about controlling access through the gate to specialist services. If you look across the countries of the developed world, the gatekeeper role, if present for primary care doctors, means strong general practice. Strong in both money and prestige. The Northern European countries generally have more or less parity of income and approaching parity of prestige to specialists. If you look at southern European countries and the USA, that's not the case at all. You get huge differentials. And the contrast is really very obvious, but just between Belgium and neighboring Netherlands, where the Netherlands has a very strong gatekeeper referral system, really similar to the UK. Belgium, it's very much a free-for-all. All the GPs are in it for themselves, and patients have direct access to specialists, and the situation is very, very different. And that there are some wonderful GPs in Belgium. My daughter was living in Belgium recently and having first-hand experience of them. But, you know, their status is way down, no doubt about it. And they don't earn so much. Then there's, if you have take comprehensive or managed healthcare systems, then gatekeeping has an integral role there. It is absolutely essential for cost control that a generalist acts in a gatekeeping role. And it was very interesting on the Commission that this was very much underscored by Dr. Valence Owen, who has a prominent role in Bupa. And he said, well, we absolutely rely on the general practitioners to keep our premiums down. Even though we know they don't do it perfectly and they're often a bit of a pushover, even so, they do a great job. We'd like them to do it better, but take them away and costs would rocket if everyone had direct access. And you could say that GP commissioning, if it happens as GP commissioning, is the highest form yet of gatekeeping in a really mega scale overview and everything. So, there are recent questions, however, about gatekeeping, and you know, a recent issue of the British Journal of General Practice published some evidence that some of us were aware of already. It's a Danish paper from Peter Vedsted and colleagues, pointing out that in Europe, gatekeeping was associated, gatekeeping health systems were associated with some delay of cancer diagnosis. And really that's not the script that the generalists have in Britain, not the enthusiasts. I'm an enthusiast. We don't have this enthusiast view of saying that we're rather slow at diagnosis. So that's a problem. And in a parallel presentation to Vedsted's paper, which has not yet been published, but he has people working with qualitative work with patients. And they come up with stuff like, well, yes, I went to see my doctor with this symptom, and he reassured me. And I didn't like to go back when it got worse, because I felt that was undermining him. And I think this shows the sort of way in which having to see a known and trusted doctor, which is the very thing I've always advocated, may not be the best thing for everybody. So there's a lot of research to be done here, teasing this out. Is it really true? Actually, for example, in the Netherlands, where gatekeeping is well established, cancer diagnosis is pretty good. So, you know, there's more to this story, but it is a big question. And on the Commission, we also had the Royal College of Pediatrics coming along and saying GPs are slow at making important pediatric diagnoses. They don't have enough pediatric training. We want specialists in the front line, first contact care. So, you know, important. I just wanted to draw your attention to the beautiful paper called The Gatekeeper and the Wizard. Full title, The Gatekeeper and the Wizard, A Fairy Story, which was published in the BMJ in 1989. Nigel Mathers and Paul Hodgkin, who are GP academics. And really it's telling about an allegorical system where the gatekeeper is obviously the GP and the wizard is the specialist, and it all works terribly smoothly as long as the patients go through the gatekeeper. But when the gatekeeper was struck ill or something, the wizard became overwhelmed and started to say, oh, bring back the gatekeeper for goodness sake. So, you know, you should read it. It's a great, I've got a list of references at the end if you want the exact reference. So, is generalism a good thing in primary care? Well, the evidence for really comes from Barbara Starfield. And she is really looking at primary care rather than generalism per se. And really her evidence can be summarized as saying there are better care outcomes, and most of this work is done in the USA, better healthcare outcomes when there are more primary care physicians in any given area. And actually Brown Jarman here published rather similar evidence in Britain, just in London, around this area. It was better to go to a teaching hospital if you were ill. But it was even better if there were more general practitioners in the area where you were. It's published in the BMJ. Starfield's other main body of work, and perhaps our most famous body of work, is about the international comparisons between health systems. Comparisons of the comprehensiveness, particularly, and the family orientation of health systems. And the UK came out very well in her comparisons. And she used these criteria. 6 criteria. Better access, better quality of generalist care, prevention, better early management of disease, the actual content and process of primary care being more appropriate when delivered by primary care doctors, and last, quite important, the reduction of inappropriate specialist care. So there's gatekeeping for you, put in there. And the ones in red are the ones which I think are most orientated towards generalist practice. So, you know, she proved fairly comprehensively, and really her evidence is best summarized in her wonderful big 45-page paper in the Millbank Quarterly, published in 2005, which really reviews all this evidence in very elegant detail. It's a lovely paper. Again, I'll give you the reference. What about the marketplace? The world out there? Well, there is great public faith in expertise and science. I told you about the view that medicine was getting too complex for general practitioners back in the 60s. Well, in my academic practice in Southampton, we undertook an experiment designed to test this. And we became specialists. I was a mediatrician. I didn't see children and I didn't see the elderly. And there was a pediatrician and a geriatrician and a maternity specialist. This all happened in a very peculiar practice in Southampton for a few years. Well, it was a rubbish experiment, I can tell you. And it was unworkable and all kinds of things. I'm very happy to talk about it another time. But it was amazing how the patients it was so easy to sell the idea, oh yes, you're going to have a specialist now. They just loved that. Oh yes, I'll see Dr. Freeman for myself and Dr. Metcalf for my child. No problem. So I thought that was interesting. And certainly, specialists cannot survive unless patients believe that they're giving them something good. And it's interesting that the American Medical Association has always opposed public health centers, public programs for the care of the poor, and health maintenance organizations. BMA is different. BMA really represents GPs, but the AMA didn't want any of this regulation. And Gordon Moore is a noted American health commentator at Harvard. And he wrote a rather entertaining article in 1992 with the delightful title, The Case of the Disappearing Medical Generalist. Does it need to be solved? And I thought his punchline was that it was never going to happen in America. The marketplace favors specialization. You want an easily understood message about your specialist expertise being better and more broad brush stuff about total quality of care and patient-centeredness and so on. When you've got a real problem and you think it's cancer, that doesn't count. So he's got a point. Anyway, generalism still struggles in the USA. I promised to say a word about non-medical generalists, particularly nurse practitioners. And we've already noted that they're increasing in their first contract role. On the Generalism Commission, we went to visit a practice in, I think it's called E1 Healthcare, which is run by nurse practitioners. They do have some GPs to sign their prescriptions. And they absolutely horrified my fellow commissioners, who were all rather conservative and wanting doctors to be best. And the nurse practitioner in charge said, we manage most of the time pretty well. Very occasionally need to consult a doctor, but not very often. And they just thought this was awful. And they didn't really go into why this might be or what sort of real experience this person had and so on and so on. So that set forth a good reaction. There's certainly different training for them. We spent a lot of time in this building and other similar ones training medical students. But nurse practitioners have a completely different, well, it's not completely different, but it's much less, it's much cheaper training. Does it matter, you know, at the end of the day? We should ask ourselves, we're good academics. We shouldn't just say, oh, Imperial knows best, do it as we do it. Which is what Imperial said when they started proposing new medical schools 10 years ago with a shorter curriculum. They said, oh, it's impossible. You can't be shorter than Imperial. There. I didn't think that was a very good academic attitude. Nurse practitioners run some practices, as I've said, primary care organizations. I say here no evidence of inferiority to general practitioners. Well, there isn't, actually. But that's, of course, because evidence isn't everything, and the studies done only cover a very small part of the role of a generalist in diagnosis. But, you know, studies keep happening, and before they're run, the doctors are rather confident that they will demonstrate superiority for the doctors, and afterwards they have to find excuses to say why they didn't find that superiority. And I think we're really into difficult questions about what does the presumed superior diagnostic training of general practitioners buy for the nation compared with that given to nurse practitioners. I think the jury's out on that question as yet. So they appear to be cheaper, and are they better? And we need better evidence. So I come to the recommendations of the Commission. And there were 11 recommendations, and I don't propose to go through them all, but I've just highlighted, what, 6 of them. And really one big thing for me going through the whole process of the Commission this summer was a realization that we haven't given enough attention to the diagnostic process in primary care. We don't know enough about how diagnoses are made and how to do it better, how to teach it better. There's been really, in my research career, looking around what myself and all my colleagues have been doing in academic primary care, there's been really very little research on diagnosis until recently. It is springing up now, particularly in Oxford. Those of you who know me will know that I've always been interested in continuity of care, and I was glad that the Commission, without any prompting from myself, came to the view that generalism didn't make a lot of sense without continuity of care. If you take the question of pediatric diagnosis, then it would seem in a way self-evident that someone trained in pediatrics is going to be better at diagnosing pediatric problems than a general practitioner. They're going to know more about the slightly less common problems of pediatrics. But the generalist should be able to make up for this because of their attributes which I mentioned earlier. The context, knowing the patient, knowing the situation, knowing what's typical for that person, all these things we've been taught. But actually, continuity of care for children is the worst. Children see anybody. It's nearly always, oh, just fit him in, will you, quickly, he's got a fever, blah, blah, blah. And Sonia here knows that admissions, acute admissions for child diagnoses of fever and others have been rising rapidly. Isn't that still right? Yes, there we are. So actually, we're recommending that continuity of care needs to be improved for generalism to have any good effect for patients. And to make that more real, we want more imaginative use of IT. There's such a sort of hang-up about appointments and face-to-face consultations. And actually, we know, and there's good research evidence, that a very personal care can be delivered in a much better and more comprehensive way, even by part-timers, when you use IT to the full. Whether it's text messages, email, telephone, or whatever. Well, there's also this question of prestige. The Commission wanted the powers that be to revise perverse reward systems. Actually, the word perverse does not occur in the report. It's not a very Commission-like word, perverse. But I would say perverse. Basically, if you have career reward systems that favor specialism against generalism, you're going to have more people and the best people going into specialism. And in particular, this is about training. And many people have pointed out that it's strange that a generalist is thought to need less training than a specialist. It's thought to be easier in some way. General practice training is shorter than specialist training. It's better than it used to be, but it's still about 3 years shorter. And there's a strong plea for longer training for GPs, specialty training for GPs, and actually more training about generalism for everybody on the way before they get into their specialist rut. And finally, very welcome, was a great boost in the last recommendation of the report for academic general practice and primary care, and specifically research, and research streams identifiable. And some of you probably know that Graham Watt is currently leading a sort of initiative to try and persuade the MRC to make it easier to fund basic, like diagnostic research. At present, if you try and go through the MRC, he says, really, as soon as you say you're general practice, you have to choose a specialty. And general practice isn't one of them. And that's all wrong. They just say, oh, it all comes through, you know, National Institute of Health, whatever. It's all about service delivery and so on. I mean, actually, we need to know about how to do our medical job diagnosis. So that's it. Those are the recommendations. This is a very rapid outline. I'm hoping there's time for a question or two, because you can take this any direction you like.